Alright guys, so I'm going to first start off by apologizing for the sound of the fan. It is hot as balls today. This is July 1st, 2024, and I am doing this video because I, as you guys are probably all aware at this point, recently had surgery for a torn meniscus as well as synovial chondromatosis. And this video is really going out to people who might discover this video, who might be going through a similar thing right now. And I am sharing with you what I've learned from this experience and how you can actually make sure that you are getting absolutely the best care that you possibly can, understanding what the data says at this point in time. Now, keep in mind again, I mentioned the date is July 1st, 2024, and so the information that I'm trying to give today is going to be most applicable to this time, as I think that over the years we're going to have different advancements that are going to come up in the how we approach and care for meniscus tears. So what is the meniscus? First of all, it is two C-shaped discs that happen to be in your knee between your two bones here. So you have your tibia down here, you have your fibula over here, you have your femur up here, your patella right here, which is your kneecap. You have the quadriceps that come into here, and basically surround the kneecap and then feeds into the quadricep tendon down here. And so when you damage your meniscus, the way that this is usually going to happen is going to be some type of twisting motion that happens in the knee. That may not be the only way that it's going to happen. There are also degenerative conditions that are going to lead to this in the future. But basically your meniscus is a cartilage tissue that protects that cartilage tissue of the bones. So the ends of your bones actually have like a layer of cartilage there that probably does actually get refreshed over time using synovial fluid, based on what I'm guessing based on my experience with synovial chondromatosis and what was going on there. But you know, that's coming from a place of ignorance. I'm not going to completely double down onto that hypothesis. So, but basically the meniscus is going to be those two C-shaped discs. Lateral meniscus means pertaining to the outside of your knee. Medial means pertaining towards closer to your midline, right? So the same thing is going to be true here. So your laterals are going to be towards the outside and medial is going to be towards the inside. And so the way that they will talk about the meniscus being torn is going to be where the meniscus tear is actually going to be. So you have these two parts here, which would be considered your horns. And so you can have tears to the horns, and then you can have tears to the middle section here. The other thing that you need to know is that there are three sections that they will talk about when it comes to your meniscus. And whether or not your meniscus is actually going to heal is going to depend on which section it's in. So this is your medial meniscus of your right knee. The innermost section is going to be more dense of a cartilage tissue, where you're not going to get as much intrusion from your circulatory system into that dense tissue. So it's very unlikely, if not impossible, for that tissue to heal on its own, versus the middle, which is going to have, you know, not a great chance of healing on its own, but it can heal on its own. And then the outermost layer, where it is most likely going to heal on its own. But because the cartilage tissue happens to be rather dense, it's going to take a long time for that to happen. Now, you know, 40, 50 years ago, the way that they would actually deal with a meniscus tear is they just remove the meniscus. But here's the thing, is that now you have no cushion in the middle of that joint that is preventing those two cartilage heads of the bones from actually sitting on each other, grinding on each other, and rubbing. And so that's going to get broken down rather fast, leading to cartilage damage and eventually the need to have a knee replacement done. So what they started to do after that is starting to do what's called a partial meniscectomy. The partial meniscectomy is where they just shave down the area that's torn to prevent it from continuing to tear even further. But there's problems with that. And I've actually already got symptoms of that kind of illustrate those problems, which is that you're reducing the amount of padding, which is already going to wear down over your lifetime anyway, and lead to bad knees when you get older, arthritis, and that type of thing. And so it's becoming more and more commonplace, although not universal, where the meniscectomy is going to be generally avoided as much as possible. Now, there is now a procedure where they will try to repair the meniscus by stitching it back together. But the recovery time for that is going to be astronomically terrible. I don't mean to scare people by saying that, but the truth of the matter is that you're looking at 6+ weeks of not being able to put load onto that meniscus. If you did the partial meniscectomy, it would be about 2 weeks. And if you don't do it at all, when you look at 6 months to a year or even 2 years out, if you were just to go into physical therapy and not do the surgery at all, you were going to have very, very similar outcomes, and potentially less of a propensity for you to develop arthritis over time. So it is generally advised now by most surgeons to actually avoid surgery at all costs. Now, are there times where you're actually going to need to have surgery? Well, absolutely yes. The biggest example of that is what is going to be a what's called a bucket handle tear. And what a bucket handle tear is it's basically a type of flap tear. And what's happening there is that the meniscus can flap up and then get stuck in the joint, and then the joint won't actually be able to roll over that meniscus anymore, and it's going to get locked. And so in that case, that piece of flap is absolutely going to need to be removed. Now, I have actually heard of several cases now, because I've joined like Facebook support groups and whatnot, where people have reported that they were trying to, because insurances want you to go through physical therapy before you try surgery for a certain amount of time, regardless of what kind of meniscus tear it is. And what happens when people follow that advice is sometimes the bucket handle tear or the flap tear can actually heal in the wrong position, and it's going to need to be shaved down anyways, which is just going to prolong how long you are in recovery for. So if you do have a flap tear, you absolutely do need surgery, and you're probably better off getting it sooner rather than later. When it comes to just a regular old tear, regardless of what zone it is, doing surgery is not likely to improve the overall outcome. So it's sometimes better to go straight into physical therapy. Now, in my case, I had a condition where I had excessive joint effusion. Now, if you see joint effusion on your MRI, if you can get an MRI, I will go into that in a moment. What joint effusion means is that you have synovial fluid that is building up in the joint. Some people will say that, oh, that's just excess swelling. Well, swelling kind of more fluid and growing of soft tissue, whereas joint effusion is just fluid just kind of floating around in the joint. So what your synovium is it's these lubricant sacs that are spaced all the way around the joint that produce lubricating fluid for the joint. So if you don't put oil in your car, what's going to happen? Well, the gears are going to grind on each other, they're going to wear down fast, the metal shavings are going to become obstructive, and eventually the car's engine will no longer operate, it'll seize up. When it comes to what happens in your knee, a very similar thing can happen. So, in both cases, right? So if you put too much oil into a car, it will actually cause problems in the car. The same thing is going to be true with a condition known as PVNS. So what PVNS is it's basically where you develop a tumor. Most of the time it's going to be benign. It's going to not be malignant in any way, shape, or form. It is not cancer. There are cases where it is. But in general, for most cases, when you have PVNS, or what I had, which is synovial chondromatosis, what is happening is your synovium has just the cells continue to grow, potentially to try to keep up with all the inflammation that's happening in the joint, so that it can keep up and try to keep that joint lubricated, so that further damage doesn't happen. Well, because the joint is filling up with fluid and, or in my case, cartilage rice bodies, the joint is now creating more space. So you're going to feel a lot more pain when you have joint infusion from all your tendons and muscles in the joint, particularly in the posterior side, because the joint is actually being forced apart, and those muscles and the tendons are now getting stretched, which is causing a lot of your pain. Now, with normal joint infusion, oftentimes a doctor can go in with an ultrasound. You want them to do it with an ultrasound. I've had it done once without an ultrasound and with improper numbing, and that is one of the most painful experiences I've had in my life. I would not let a doctor, knowing what I know now, go in without using an ultrasound. So How this works is they're going to take a very large syringe with a pretty big needle, because it's going to be a very thick, viscous liquid that they're going to be pulling out of your joint. And so what they'll do is they'll spray it to get it cold and kind of numb the area. This will allow them to take a much smaller needle with a numbing solution, put it into the joint, so that you're going to feel less of what's going on there. They should be doing they should be doing any insertion of the needle with an ultrasound, because you do have nerves, you do have blood pathways, you have the menisci that you don't want to do further damage to, you have all these structures that you need to avoid, and so the ultrasound allows you to guide the needle in so that it is done properly. So once they've numbed it, they can go in and then they can extract fluid using the ultrasound. Now in my case, they saw a bunch of floaty bits going around inside the joint when they were doing this, and the reason why they were draining my joint in this case was so that they can do PRP, platelet-rich plasma, which I'll get back to in a moment. And the thing is that some joint effusion is going to be pretty normal, right? It's actually not problematic at all. Some low levels of PVNS will resolve themselves on their own, while others are going to require some level of synovectomy, which means a shaving down or a reduction of the synovium. They do not take the synovium completely out, or at least I don't think they should. So what they're doing is they're basically hindering the ability of the synovium to continue to fill up your joint with fluid. If you have PVNS, unfortunately the prognosis for when you do go in and shave it down is actually rather low, or not that great, because you have a pretty good chance, I think it's like a 25% chance or something like that, that the synovium is going to basically replicate itself again, become a new tumor, and continue to produce more fluid in the joint that's necessary, and so it can become a recurring problem that shows up every 2 to 5 years. So the prognosis is not great on that, and hopefully we've come to a point where we actually understand a better way of handling it. And since they did not diagnose me with PVNS, I don't know whether there are drugs or anything like that that can actually help with the reduction of the inflammation, so that the synovium's not cued to continue to produce all the excessive fluid. So going into that a little bit deeper, when it comes to trying to get the right care, because what happened with me is when I was going in for PRP, they drained out my fluid. Now, if they drained my fluid and it stayed drained, then you probably obviously don't actually need to go in and address the synovium. Oftentimes a single draining will do the trick, and you're going to feel a lot better having had that synovial fluid drained. But if you do have rice bodies that are showing up in there, we didn't know what the rice bodies were. So the first thing that we wanted to do is we wanted to go ahead and have the fluid tested. When I was with Kaiser, the orthopedist that I saw said that he doesn't do joint fluid draining because it's dangerous, and that testing it would not necessarily show anything, and effusion is generally normal. Now, by the time I actually saw him, I was probably 8 to 10 months into this. Joint effusion lasting for that long is actually rather abnormal, and it was really on to him to acknowledge that it was abnormal for it to stay that long. Since the meniscus tear was since I was first seen for the meniscus tear with my primary care provider, and I'd already at that time done several months worth of physical therapy, where we were kind of poking and hunting in the dark, and we did not know what was going on. So because I had to fight in order to get my MRI, it's, if you have an injury and you don't know what the injury is, and they can't necessarily call it just by doing joint manipulation, yes, you can have a meniscus tear diagnosed through joint manipulation. And actually that is how I found out that I had a meniscus tear, still have it, was that my chiropractor did the joint manipulation, was like, you're testing positive for meniscus tear. But also, he also acknowledged that it was really weird. So I had to demand the MRI. My primary care provider wouldn't do the MRI. And the thing about that is that if you think that you have a meniscus tear, or you suspect it, like there's no ligament damage necessarily, and there are positive tests for a meniscus tear, you absolutely do need to get an MRI. And having it avoiding that is potentially putting you at risk, because again, if you have a bucket handle tear or a flap tear, that absolutely needs to be taken care of surgically, and they cannot tell if it is a bucket handle tear or flap tear just by doing a joint manipulation. Now, they might say, well, you know, we're not seeing signs that this is because you're not locking out regularly, or you're not reporting that. You're not having popping or other things that make them think that it is more of an obstructive tear, like a flap tear, right? And so they might think that way, but it's the MRI that's actually going to show that. They cannot necessarily cause that to happen when they are doing their joint manipulation assessments. So you really need to know, especially when you have prolonged ongoing joint infusion that is getting to the stage where it's been months and months and months, like more than 6 months, and it's still a problem. And especially if you have floaties in it, because there could be cancer going on in there. There could be a candida infection going on there. There was one person in China who had synovial chondromatosis in their shoulder, and they didn't know what it was, so they went in surgically, they found the rice bodies, they removed it, and then 2 weeks later when he went back for his follow-up to have the stitches removed, he was still having pain. They looked in there and they're like, oh shit, you have synovial chondromatosis still. And because they hadn't tested the fluid, they didn't know that there was a fungal infection that was causing the problem. So if they don't treat the fungal infection or the bacterial infection because they never tested the fluid, then you're going to basically be hitting the same wall over and over again, and you're not going to actually see any relief from what you're doing. So, you know, you do need an MRI. You do need to know how much joint effusion that you have. You do need to get it drained if it is a normal large amount of joint infusion that may be causing more symptoms. If you have to get it drained more than once or twice, then it should really, really be tested. And no, a doctor cannot drain your fluid, as the second orthopedist did, look at the fluid, and determine that there is nothing abnormal about the fluid. Right? He threw it in the trash, and then my primary care provider now actually had it tested. It came back negative, so there was no bacterial issue, there was no fungal issue, but I did have synovial chondromatosis, and so he referred me to, and he didn't know that, he just knew that there's floaties that need to be investigated, so he referred me to my now orthopedist, who is a research orthopedist, who looked at that and said, well, we think you at least have PVNS, so we need to go in there and at least do a biopsy on your synovium to determine whether or not it needs to be shaved down or not. And then when they got in there, they're like, oh look, rice bodies! You've got this really rare thing called synovial chondromatosis, which is just that your joint is literally filled with cartilage bodies. Now, there are only about 1,000 cases of synovial chondromatosis every year. PVNS is much more common, and so it's very unlikely that most people will actually find that. But the point of this is that you actually do have to fight to get the MRI. You need to actually sit down with your orthopedist. The PA is fine, somebody who knows how to really read the MRI, and go through that. And you need to ask, you know, does my synovium look normal? Does my meniscus look normal? Are all my ligaments intact? Is there any sign of patellar chondromalacia, which is a wearing down of the cartilage tissue of the patella, which can also cause problems in the knee? And, you know, where is the meniscus tear? Is it a flap tear? Can you tell? Sometimes they can't even tell on the MRI because the flap tear is sitting in a good position at the time the MRI is done. So nothing is 100% certain, but one of the key points is that for most people, going in surgically is not the right answer. You do not need to have a partial meniscectomy. You probably won't benefit from having it stitched, removed in any way, shape, or form. You probably should leave your synovium alone. But there are conditions where surgery absolutely is the only and best option that we have on July 1st, 2024. So I know I've been talking a lot, I've been talking really fast, and I've been a little bit all over the place with this, but when it comes to how you respond to the possibility that you have a knee injury that might be a meniscus tear, you know, the effectiveness of PRP is going to depend on how soon that you start it. So if you do the MRI, you've determined that surgery is not the option for you. There's no sign of synovial chondromatosis. There's no sign of PVNS. PRP would be a good option for you to integrate in along with physical therapy. So what PRP is that where you take your blood out of your body, you spin it through a centrifuge. It's going to separate out so that they can extract the platelets and the plasma, and then they re-inject it into the area. And as I mentioned before, the meniscus actually has zones where it doesn't get a lot of circulation. So by placing those platelets in that area, you have a pretty good chance of getting your meniscus to actually heal itself. The thing is that you need inflammation for that to happen. And one thing that a lot of people get wrong is they do the PRP, but then they take ibuprofen, they take aspirin, they take any type of NSAID, right? The third one is, I am completely forgetting the name of it. But it's not acetaminophen. Acetaminophen, not to be confused with aspirin, is Tylenol. It is hard on your liver, so don't overdose on it. Take it just as much as you need. But that is going to be the better route than taking a non-steroidal anti-inflammatory drug, because we do not want to reduce the inflammation in the joint when you are taking PRP. So what PRP is going to do is going to try to get to heal. Now there is a acid, it's like a hydrochloric acid or something like that, I know I'm getting that wrong, that they can inject in there, and that has seen relatively good results. But what I would not recommend is doing any type of cortisone injection. Cortisone is a steroid that they inject into the joint, and if you are doing physical therapy and you are trying to heal the joint, and you are in too much pain to make the physical therapy actually effective, then doing the cortisone injection might actually be a good thing, because it's going to reduce the amount of pain that you have in the joint so that you're actually able to do your physical therapy. It lasts usually up to 2 weeks, and you can do it, I think, once every 3 months. So it's not going to last very long, but it can give you the head start that you might need in order to strengthen up the muscles around the joint so the joint becomes much more stable. So, but the thing is that cortisone injections actually weaken the meniscus and the joint tissue over time, and so doing repeated cortisone injections more than you actually need in order to do your physical therapy is actually going to weaken the joint even further. So there are other technologies that may help you with that. There are TENS units which are going to basically not numb, but they're going to desensitize some of the nerves in the area so that you're going to be in less pain while you're doing your exercises. So that can actually be something that can be helpful. I'm forgetting the acronym for it, but there is one that actually targets the muscles more. So if you see the units that are both 10 units and the other type, they're going to be a different type of frequency that's targeted more for the muscle to try to get the muscle to activate and grow. Some research has suggested that that might be beneficial. There is also the Nubi, which is a DC current instead of an AC current type of therapy that is supposed to help with that. A lot of people swear by the results of that. The only studies that I've seen are on the Nubi site. I haven't, except for some studies like decades ago that were looking at DC current for physical therapy, and they found that it was not particularly helpful for muscle regrowth, strengthening, or nerve desensitizing. So how beneficial doing DC current or the Nubi is going to be kind of questionable, just not because maybe Nubi didn't do their research well, or that they were able to look past their bias because they're selling a very, very expensive product and they need to be able to justify it. So they could have manipulated their studies in order to make it sound like it's more beneficial than it actually is. That is a possibility. And I'm not trying to knock Nubi by saying that. I'm just saying that the research that I was able to find on all their claims is pretty much limited to them. So the conflict of interest is obviously there. Moving on. The other thing is, so the problem when you get a meniscus tear or you get a ACL tear or any type of ligament tear, some people will try to tell you that you don't need to try to do surgery to try to repair the ligaments. I don't know really where all the research really is on that. I know that the way that they repair it is that they take part of your tendinous tissue from your biceps, femurs, your hamstrings, and they'll use that to replace the ligament of the tendon. If you have a partial tear, then PRP might be a very good route for that actually, because it's going to encourage that tissue of the ligament to actually heal itself. Whereas if you have a full tear, then it's disconnected. It might not actually be able to touch itself, so it might not actually be able to make that full connection back again. Some people might jump in the comments and argue and say that that statement is totally false, and if they want to point to the research or the doctors that are saying that, then I'm happy to listen to them. But I think that logically speaking, I think surgery is probably the right answer in that particular case. But that just depends. Some people do actually forego the surgery, and they're able to strengthen their muscles around there to basically take on the same role that those ligaments were doing. So it doesn't necessarily mean that surgery is going to be absolutely necessary in that case. I just seem to be a little bit biased towards thinking that it is. So, take that with a grain of salt. So, moving on. Yes, other things that might help you with your recovery. So the problem is that because you have this injury and you're going to have some atrophy from the injury because of the inflammation in the area, your body's going to try to take resources from nearby tissue to try to recover that. And if you have PBNS that needs to be shaved down, or you have synovial chondromatosis that needs to be shaved down, that's going to be a much rougher recovery than a partial meniscectomy. You'll be able to put weight on the joint much sooner, but you are going to be absolutely crashed for the next several weeks, or at least I was, because of the soft tissue that was attacked. And because of how rare these things tend to be, a lot of people, including my physical therapist, were not aware that that was going to be the issue, so it was really difficult for me to actually perform in there or even do things around my own house, which, by the way, I have a new couch. Do you like it? Because the amount of load that you can put in the knee without doing damage is so reduced, we have to actually start looking at ways of developing muscle in that area without putting as much tension onto it. So, and you guys will see me use this in a little bit. I have a little bit of extra money right now, so I went ahead and I splurged on the air bands, which are not the most expensive ones that you could get, but these are BF blood flow restriction training cuffs. And the theory behind blood flow restriction is that because you don't have blood flow leaving the muscle tissue, you're going to have more of a lactic buildup in the muscle, which is going to cause more breakdown. And because you're doing activity, you're going to have the hormone responses required to rebuild that muscle. So you're going to have more muscle breakdown with less resistance and less volume if you're doing BFR training. Now, the problem with BFR training is that when you have surgery, you have the potential of damaging blood vessels, which can lead to blood clots. This is going to potentially increase your risk of blood clots, and which can lead to pulmonary problems, heart problems, stroke, so the blood clots can move, loss of tissue, things like that. So I'm not going to say that there are no risks when it comes to BFR training, but they do, and you're also going to have the extra load that I wasn't expecting following my workouts quite specifically, because the thing is that you have all this lactic buildup that's happening right here, and it's not being moved out of your tissue very effectively because this is reducing your blood flow by about 80%. And so that lactic buildup is just sitting there, and once you finish your 15 to 20 minute workout, which is as long as you should ever do BFR training, once you finish that session, all that lactic acid and that buildup is going to get released into your system. And then, so if you've ever done like CrossFit, or you've ever done high intensity interval training and you weren't quite ready for it, and you get that like nausea, dizziness, and all that stuff, it is actually really common with BFR training, even when you're not doing as intensive a workout. Not saying that BFR training is not intense. It is, oh my god, it is actually kind of terrible. The thing is that, if you've ever lifted really, really heavy weights, you're pushing that weight and you are building up lactic acid in that muscle. That's going to cause the muscle to burn, it's going to make it fatigue, and your muscles are not going to want to work, and it hurts, a little bit. And so BFR training basically makes it so that hurt doesn't go away for 20 minutes. And so once you kind of build that up, you're like, oh shit, now my muscles are really fatigued, it's burning, it is like I just did a really, really intense workout, and boom. So because you are doing this, you are, and it doesn't necessarily just affect this muscle, right? That's below where the cuff is placed, which is going to be up here. You can do it for your glutes as well by restricting the thigh as well. And that's the same with shoulders and chest. That's just what the studies say. I'm not sure that I completely subscribe to that at this point, but maybe, yeah, I don't know. It's hard to say. I would have to see a lot more data on that. But for the muscle tissue that we're actually trying to use for the most part, which is trying to stabilize this joint, other than your glutes, all the quads, the hamstrings, your adductors, your abductors are up here, they're your glutes, right? Those need to all be strengthened and built up. And for me, it's a lot of this vastus lateralis. That is the one that really, really seemed to shrink the most for me. And that includes also your below leg muscles. So, I feel like my popliteus right now is very weak. That's the muscle right here that attaches here and goes diagonal here. That's where a lot of your pain for meniscus tears is going to appear. And I have trouble actually keeping my toes pointed more medially, so I'm having more external rotation with my foot than I used to, which oftentimes is a sign of tight calves, but I think in this case it actually is more of the atrophy of the popliteus. So that is something that I'm incorporating into my workout. And so basically the point of all this is that you're going to experience some atrophy, that this is an option that you can look into, as well as me advocating for PRP. What is recovery like? And how should you utilize support groups? Because that is one of the big things here. So here's the thing, is that I am in the Facebook support groups for meniscus tears, and one of them is very, very, very prone to trying to deter people from having surgery. And while they are good intentioned, they also don't have much nuance to the claims that they're making. They just kind of blanketly say, okay, you don't need to have surgery because you have a meniscus tear, and this is what the data says. And they don't believe, that a bucket handle tear or something like that, a flap tear requires surgery. And they're just flat out wrong with that. I'm sorry, but they are. And so when you're looking at advice when you're coming to a Facebook support group, a lot of people are going to apply their personal anecdotal experience to your experience, and they are not qualified to do that. A lot of people post their MRI scans asking people, to interpret them. I actually went onto YouTube and I learned how to interpret my MRI, and I could find what they were talking about in the summary, and I knew what my meniscus tear looked like and a lot of the conditions for that, but I missed that I had PVNS/synovial chondromatosis. So, even if you do everything that you can to try to learn how to interpret an MRI, or your doctor sits down and interprets it with you, you're probably still not going to be qualified to actually interpret that well. So really, it's imperative to make sure that you are sitting down with your orthopedist or your primary care provider, whoever is actually qualified to actually read and interpret your MRI with you, and actually look through the images. Tell them, no, I want to see my tear, and I want you to tell me to my face that this is one that is going to benefit from surgery or not, and tell me exactly why. Because in some cases, my first orthopedist was very surgery gung-ho, right? He absolutely wanted to jump into surgery, but he only acknowledged the meniscus tear. He looked at my joint effusion and said that that was normal, and it absolutely was not. The second orthopedist supposedly looked at my MRI. He did a bunch of x-rays and whatnot, and I think that's what he was really going off of, and said he did not believe surgery would benefit me. He was also condescending and ignored my joint effusion and the rice bodies that we had seen in there, saying that, whatever floaties are in there, it's probably just some regular debris, but I don't think surgery is going to actually benefit you. And again, he looked at my fluid, threw it in the trash because nothing was sucked up with it. Rice bodies will not fit into the needle, so fuck him. Third one actually sat down with me and was like, did nobody actually look at this? Did they not notice the synovium, and nobody paid attention to the fact that you have things floating around in there other than my PRP doctor who was seeing it on the ultrasound? No. So I think it's absolutely critical that you don't just let the imaging department write up a summary and let the doctors go off of that summary. But you really need to sit down with your doctor. You need to ask questions, and you need to get multiple opinions, especially regardless. Like if you feel like your doctor hasn't really given your case the special treatment it deserves, then you need to be getting a second opinion. So that's my long-winded everything that you need to know about your MRI, meniscus tears and whatnot, and getting the care that you need. And I will be going into like the different things that we've been doing in my rehab. And you know, I know that you might be saying, well, you had synovial chondromatosis, so you're no longer in the meniscus tear category. Well, I actually do have a meniscus tear, and PRP actually did a lot to heal my meniscus tear, but it's still there a little bit. And so when I have the post-surgical okay to go back to doing PRP, I'm going to do it to try to get that to heal the rest of the way up, as well as doing some work in my tendons. But as far as like my rehab goes, like I'm basically at the point right now where I am rehabbing a meniscus tear that was not surgically corrected. So I will bring you into that journey as I continue to go on to it. If you were hoping for a more hopeful message, I again recommend that you go look up Chewjitsu. That's Chewjitsu. So it's Brazilian Jiu-Jitsu, Chewy, and he has done several videos on his experience with two different meniscus tears 10 years apart from each other, and how he handled each of those, and what the end results were. So I think that if you're struggling with that, that is a very good resource for you to look into in order to kind of get a better idea of the surgical repair side of it and what that journey is like. So thank you guys for watching. We will get into exercises here rather shortly. Thank you.